I'm Dr. Maryam Lustberg, and I'm joined today by two colleagues from the Yale Breast Program, Dr. Sarah Schellhorn and Dr. Dan O'Neill. We're all breast oncologists, and we will be focusing on today on all aspects of metastatic breast cancer in terms of systemic therapies. What are we currently using in the clinic, as well as clinical trials, as well as some of the newer emerging therapies. There will be ample time for questions, so as you think of questions, feel free to put them in the Q&A portion of the portal, and we should have time to get to most of your questions. So the focus tonight is, as I mentioned, on metastatic breast cancer, where the primary most effective therapy is a systemic therapy. So we'll be talking about the different subtypes of breast cancer and what the different management strategies are. With that, I will turn it over to Dr. Sarah Schellhorn.
Thank you, Maryam, and welcome to everybody. I'm delighted to be here tonight. I just took a quick peek over at the attendee list and I see some familiar faces. So for those of you I know, welcome. And for those of you that I don't know, welcome. But Dr. O'Neill and I have divided up our time. We were asked to prepare 10 to 15 minutes of information about metastatic breast cancer. And so we divided that into two groups, and I'll be discussing primarily two subtypes of breast cancer, HER2 positive and triple negative metastatic breast cancer. And Dr. O'Neill will be taking on the huge topic of hormone receptor positive breast cancer. And this is easily this topic could easily take up several hours. We could wax poetic for a really long time. So trying to condense this to just 10 to 15 minutes was a challenge, but we will give it a try. So very, very quickly, what is metastatic breast cancer? As many of you likely know, it's cancer that started in the breasts. And when cancer starts in the breasts, it starts to develop two basic characteristics that make cancer cancer. One of them is the ability to grow without any controls or without the normal controls of a cell. And the second is the ability to invade. And cancer cells can develop in normal breasts. They can become a little bit atypical. They can start to form cancer that stays within the breast and stays within the lobes or the ducts of the breast. Then they can become invasive and develop into metastatic disease. When those cancer cells invade, they break through the lining of the duct or the lobe and start to invade into either the bloodstream or the lymphatics and travel to other parts of the body. So the definition of metastatic breast cancer is breast cancer cells that have traveled to another part of the body. And the most common places for breast cancer to go are the lung, the liver, and the bones, with a fourth most common location being the brain. And when we think about how metastatic breast cancer is treated, we first look at three different proteins. We look at the estrogen receptor, the progesterone receptor, and a protein called HER2 on every breast cancer specimen. So the pathologist looks at a biopsy specimen, looks at these cells under the microscope, and measures the amount of estrogen receptor and progesterone receptor, and then a protein called HER2. We'll talk about it in a second. And I'm going to leave a little of this for Dr. O'Neill, but estrogen and progesterone are female hormones that even after menopause are circulating in some level in the bloodstream. And the presence of the estrogen receptor and presence of the progesterone receptor on a cancer cell means that that cancer cell is fueled, at least in part, by those hormones. So cancers that have the estrogen and or progesterone receptor are hormone receptor positive and tend to respond to anti-hormone types of treatment. So that's the subject of Dr. O'Neill's whole spiel, which we'll get to in a second. The third protein that we look for is a protein called HER2. And HER2 is a protein that sits on the surface of cancer cells, and it's there in low numbers normally, but sometimes it can be present in higher levels. And when it's present in higher levels, that can be the driving force for cancer. So lots of HER2 can make those cancer cells want to grow faster and spread quicker. And so, the topic of my portion of this program is HER2 positive breast cancers, and then another subtype called triple negative breast cancer. And so we talked about the three different receptors that we check: the estrogen receptor, the progesterone receptor, and then this protein called HER2. And when the cancer cells do not have any of those three proteins, that's 1, 2, 3 proteins that are negative, it's where we get the title or the name triple negative breast cancer. So I'm going to first start with triple negative breast cancer. These aren't cancers that are fueled by hormones. They're not fueled by having extra amounts of HER2. And unfortunately, that means that the mainstay of treatment is chemotherapy drugs. And these are chemotherapy drugs that are generally given through the vein in an intravenous fashion. And these drugs go everywhere in the body with the idea of trying to kill cancer cells wherever they might be. And we have lots and lots of chemo drugs that work in breast cancer and in triple negative breast cancer. But they have lots of side effects. This is one of the big problems with chemotherapy. It can affect almost every organ system in the body, from the brain all the way to the muscles, from the lungs to the genitourinary system. Any part of the body can be affected by chemotherapy because it's not particularly specific. It doesn't target anything. It really affects any cell that's growing. And that can be normal cells like the lining of the gut, normal cells like they're in the skin, normal cells anywhere. Furthermore, chemotherapy has some even more downsides. It's inconvenient. It requires frequent visits to clinic and to infusion. This can impact things that are really important in a woman's life, like childcare, trying to arrange transportation. These drugs are generally intravenous, which means that getting an IV over time can be more and more challenging because every time you put an IV in, you create a little bit of scar tissue. It can lead to loss of work productivity, which can cause what we call financial toxicity or financial harm to people who have to deal with chemotherapy over the long term. And it can have tremendous effects on a woman's mental health. In fact, this is work that I did a number of years ago. Not just physical concerns impact people getting chemotherapy. And when we showed that almost half of patients, or over half of patients, have more concerns with things that aren't physical. So I apologize if this feels a little bit choppy, because it is. There's just a lot to say here. Some of the most exciting drugs that we're using now belong to a class of medicines called antibody drug conjugates. So we talked a little bit about the fact that chemotherapy is, it targets all different types of cells regardless of where they are. But antibody drug conjugates, I like to think of them more like tumor-seeking missiles. So there's been a lot of talk about antibodies over the last 5 years since the start of the COVID pandemic, but antibodies are proteins created by lymphocytes in part of the immune system. but we can create antibodies in the lab. These are called monoclonal antibodies, and they basically are like targets for particular proteins. So you have an antibody to a particular protein. And so what an antibody drug conjugate is an antibody that's targeting a protein on the cancer cell, and riding along with it, attached to the antibody, is a chemotherapy drug. We call that the payload. The chemotherapy drug is riding along with the antibody. So the antibody finds the tumor, it finds the protein that it's looking for, it binds to that protein, and it delivers the chemotherapy directly to the tumor. And there are a few different antibody drug conjugates that have come about over the last 5-10 years, and we'll talk about most of them here. The second class of medicines that's used in triple negative breast cancer is immunotherapy. And immunotherapy targets the immune system, and more appropriately, it actually takes the brakes off the immune system. So in the presence of cancer, the immune system kind of says, well, that looks a little bit like me. It looks a little bit like self. I'm going to back off. So the cancer cell kind of puts the brakes on the immune system, not allowing the immune system to fight the cancer. But immunotherapies like Keytruda, probably the one we use most commonly in breast cancer, but there are others used in other types of cancers, works to take the brakes off the immune system. So it allows a patient's body, a patient's own immune system to help fight the cancer. And that reactivates the immune system so that in combination with chemotherapy, the immune system can then fight the cancer and get a more robust response. So immunotherapy is another class of medicines that we use primarily in triple negative breast cancer. And finally, another target that's applicable for several types of breast cancer, but those particularly associated with BRCA1 and BRCA2 mutations. These are called PARP inhibitors. And PARP inhibitors have to do with normal cell division. And people who have these types of mutations in BRCA1 and BRCA2, in the normal process of cell division, they make mistakes. They make more mistakes than is usual. And when those mistakes happen in the normal process of cell division, cancers are much more likely. The PARP inhibitor, well, actually, people with these mutations aren't able to repair those mistakes in as an efficient way as someone who doesn't have those mutations. And PARP inhibitors work by preventing repair and basically lead these cells to commit suicide. So PARP inhibitors are pills that we use fairly frequently in people that have these types of mutations. So moving very quickly to HER2 positive breast cancer. So remember, HER2 is a protein that's on the surface of cancer cells. And when HER2 is there in high levels or it's overexpressed, that's the primary driver for growth of those cancer cells. And up until maybe 25-ish years ago, this was really bad because HER2 positive breast cancers were very aggressive. They had high likelihood of developing into metastatic disease and high likelihoods of going to major organs like the liver and the brain. But again, about 2.5 decades ago, the drug trastuzumab or Herceptin was developed, and it revolutionized the treatment of metastatic breast cancer first, and then earlier stage breast cancers a little bit later. And that began a long history of targeting HER2, first with trastuzumab, and then later with additional antibody drug conjugates, other monoclonal antibodies, and oral medications called tyrosine kinase inhibitors. This is just the history of HER2 positive breast cancer. way back to 1935, and not a whole lot happened between 1935 until the 1990s. But starting in 1998, when trastuzumab came about, there have been many, many drugs that have been approved in various settings. Lapatinib, pertuzumab, a drug called TDM1 or Kadcyla, neratinib or Nerlynx, paratinib, tucatinib, neratinib, margetuximab. All of these drugs have come about over just the last decade or so in for patients with HER2 positive breast cancer. So really quickly, HER2 positive breast cancer is primarily treated first with HER2 antibodies, primarily trastuzumab and pertuzumab, which target that HER2 receptor. And these can be administered either via infusion or a shot. And they're often used together because they block HER2 in complementary ways. Then there are oral HER2 drugs like lapatinib, neratinib, tucatinib. Sometimes I wonder who actually names these medications. There's a lot of vowels there. These are hard to say. But these medications block the intracellular signaling that comes from the HER2 receptor, leading to cell growth. And then finally, antibody drug conjugates, the tumor targeting missiles. They have a place in the treatment of HER2 positive breast cancer too. In fact, the two most common antibody drug conjugates are HER2 targeting antibody drug conjugates. The latest antibody drug conjugate to come through the pipeline is a drug called Enhertu, which is trastuzumab antibody targeting HER2, coupled with a chemotherapy called deruxtecan. Another antibody drug conjugate called Kadcyla or trastuzumab emtansine is that Herceptin antibody coupled to a chemotherapy called emtansine. And these two drugs have not only provided us with two additional treatments, data coming out just in June of this year, looking at trastuzumab deruxtecan or Enhertu in the first line setting for people with metastatic HER2 positive breast cancer. Occasionally, we also use chemotherapy in HER2 positive disease combined with trastuzumab. And then for patients that have HER2 positive and also hormone receptor positive breast cancer, we also use endocrine therapy. I know I've already gone over the time that I said that I would take, but I wanted just to mention the way that new drugs come up and they get approved by the FDA is through a series of clinical trials. And clinical trials require patience. This is how we determine whether a drug is effective or not. And we look at new combinations of drugs and compare them to older combinations. It's how we move the field forward. Clinical trials could also be called clinical studies, research trials, protocols. But a clinical trial is more than just a lab test or a test on a guinea pig. Clinical trials afford patients an opportunity to contribute to the field and potentially get highly effective therapy even before it's approved. There are lots of phases of clinical trials, starting at the earliest phases where we're studying new drugs or new combinations of drugs and looking at toxicities, all the way to phase 3 clinical trials, which are usually randomized clinical trials where there are multiple arms of the trial. And even phase 4 clinical trials, which happen after a drug is approved. And the likelihood that a drug becomes FDA approved gets lower and lower the later the phase of the trial. That is all that I had prepared for triple negative breast cancer and HER2 positive disease. But I'd love to turn the proverbial microphone over to Dan O'Neill my colleague, who is also a practicing breast medical oncologist, to talk about hormone receptor positive breast cancer. And I will stop sharing and turn it over to you, Dr. O'Neill.
I'm told I'm muted. Okay. Thank you. Thank you to Dr. Schellhorn for doing the impressive work of laying a lot of the groundwork about what metastatic breast cancer is and the different types of metastatic breast cancer. I'm going to be talking about hormone receptor positive breast cancer, and specifically hormone receptor positive HER2 negative breast cancer, where we don't have overexpression of that HER2 protein. And just like Dr. Schellhorn described, hormone receptor positive breast cancer is breast cancer that has expression of that estrogen receptor and/or that progesterone receptor, and is usually primarily driven by the estrogen and progesterone hormones that women are making, really over their entire lives, to some amount, and that you see circulating in the blood in a healthy woman. There have been a lot of updates in this space. I gave a similar talk about 2 years ago, and when I went back to my slides for today's talk, I had to make a lot of updates. So that's really good news. I'm going to talk about a lot of specific drugs that we're using, and how we sequence those. So to start out thinking about the first line setting, or the initial therapies that a woman is likely to receive for a new hormone or metastatic hormone receptor positive breast cancer, the standard there has remained the same for some time now. The standard therapy is a combination of a couple of different types of drugs. The first type of drugs are kind of essential anti-estrogen backbones, either aromatase inhibitors usually, which are an oral medication, or a injectable medication called fulvestrant. And those two medications have been around for a long, long time. But within the last several years, a newer type of medication, a CDK4/6 inhibitor, has been incorporated into the treatment combination as well. So CDK4/6 inhibitors are drugs that inhibit a pathway that is part of the process that stands between the estrogen receptor and the cell, telling the cell to divide in response to estrogen. So these CDK4/6 inhibitors interfere with that signaling, with that communication, and they help the endocrine therapies, the anti-estrogen therapies, work for longer than they would all on their own. There are 3 different CDK4/6 inhibitors that are available on the market. They're palbociclib or Ibrance, abemaciclib or Verzenio, and ribociclib or Kisqali. And in the clinical trials, looking at how long they improved the time that a cancer was controlled in that first line setting, the results were pretty similar. The average amount of time that a cancer could be controlled with these 2 drugs together was around 2 years, or a little bit longer than 2 years, and that was consistent across all 3 drugs. In addition to that, there have been studies that look at how long overall life expectancy is improved by using these medications early on. And there are maybe some differences that have emerged in what we call real world trials, or trials looking at patients, actually out in the clinic receiving the drugs. There was a suggestion that all 3 drugs improved life expectancy. In the kind of well-controlled clinical trials that led to the approval of these drugs, ribociclib was probably the best performing, increasing life expectancy by about a year. So that's the first line setting. That's been stable. A lot of the newer approaches and newer medications really start to crop up in the second line setting, and in one situation in first line setting that I'll describe. When you're looking at the next therapy, when the cancer is no longer well controlled with those first drugs, something that's really important sort of thematically is to think about targetable mutations and how those play into treatment selection. So to sort of explain that, as the cancer is growing and becomes metastatic, or continues to grow despite medications, it's sometimes undergoing genetic changes and developing specific mutations. And in some cases, these mutations have drugs that are linked, drugs that target those mutations effectively and can be particularly effective in those cancer types. But you need to have genetic testing to identify those mutations. Importantly, this sort of the mutations I'm referring to refer to the mutations in the cancer cells. They're different from the mutations that are in the healthy cells of a woman's body that might have been inherited by a family member. So this sort of genetic testing is different from the genetic testing that many women undergo when they're first diagnosed with a breast cancer, be it metastatic or not metastatic. And it really includes testing the tumor tissue itself. As I mentioned, the mutations can guide treatment selection. And this testing can be performed in a few different ways. The most straightforward way probably is directly testing the tumor tissue itself. And that would require a biopsy of the tissue so that there was some tissue available for testing. Alternatively, sometimes you can do testing just on using a simple blood draw. In that case, what's called circulating tumor DNA, or DNA that's in the blood that's been shed by the cancer, can be isolated and tested for mutations. And an important thing to also keep in mind is that, as I sort of described a little bit already, these mutations do have a tendency to develop and to change over time. So each time a new treatment is being considered, it can sometimes be helpful to repeat testing. So I said there was a circumstance for initial therapy where identifying a targetable mutation can be helpful, and I'm going to describe that. So this is a relatively new approach. The specific circumstance I'm referring to are for breast cancers that meet two criteria. The first criteria is that the breast cancer recurred while a woman was taking what's called adjuvant endocrine therapy, or kind of preventative anti-estrogen therapy, while she was in remission from her early stage breast cancer, or the breast cancer recurred within a year of finishing adjuvant endocrine therapy. And then in addition to that, the breast cancer needs to have a PIK3CA mutation. When those two criteria are met, there is a new combination of 3 drugs that can sometimes be helpful for first-line treatment, for that initial treatment. And those 3 drugs are fulvestrant, the older endocrine therapy I described earlier, palbociclib, one of the CDK4/6 inhibitors from that first slide, and then a new medication called inavolisib, which is a PI3 kinase inhibitor pill. It's an oral drug that targets this PIK3CA mutation. The advantage of this triple combination therapy is that it works to control cancer for longer than just fulvestrant and palbociclib by themselves. So it can control cancer in about 60% of women, as compared to just about a quarter of women with that set of circumstances I described when you're using just those 2 drugs. In addition to controlling cancer in more women, it also controls cancer for longer, typically about 9 months longer. So it seems to work considerably better than the old 2 pair of medications. A tricky thing about these combinations of multiple drugs is that as you add more drugs, you do often see more side effects, and that can be a challenge. And that was indeed the case with these medications. So side effects that are common with these 3 drugs together include diarrhea, mouth sores, and sometimes high blood sugar levels. So just as important as finding the right cancer treatment, the other thing you have to do with your oncologist, and we spend a lot of time doing, is working together on trying to control side effects. Okay, so moving on to the second treatment. Or moving on to the second line therapy, excuse me. For a long time after that aromatase inhibitor treatment stops working in the first line setting, the standard approach was to move on to this fulvestrant medication. Fulvestrant is an intramuscular injection that you have to receive every 4 weeks, which is not necessarily a pleasant treatment to be receiving. On its own, its response time, or the response time of the cancer, is not always as long as we would hope. And so there have been a number of different options that have been developed recently to try to improve on those outcomes and to improve on just the experience of receiving the drug. So the first options I'll go through are drugs that target the ESR1 mutation. The first of those is a medication called elacestrant. Elacestrant's been on the market for about 2 years now. It's a pill. It's not an injection. It's a pill that has the same mechanism as fulvestrant. It's what's called a selective estrogen receptor degrader. Compared to fulvestrant, in women who have an ESR1 mutation, it controls cancer longer. So it works better than fulvestrant in addition to being an oral medication for women with an ESR1 mutation. It seems to work best, and really that extra benefit is mostly seen in women who whose cancer was controlled for at least 12 months on their first-line anti-estrogen therapy. So those are women who, it seems like their cancer is still sensitive to anti-estrogen therapies. And it can have some side effects, but usually they're not particularly difficult. It can have a variety of GI side effects. It can have some of the same sort of anti-estrogen menopause type side effects that you see with other anti-estrogen medications. There is a practically brand new option for women with ESR1 mutations that is similar in some ways to elacestrant. It's called imlunestrant. Also a lot of vowels in that one. It is also an oral SERD, just like the elacestrant. Just like elacestrant, it controls cancer for longer than fulvestrant amongst women with ESR1 mutations. What makes it a little bit different is that in the trial that led to its approval, there was a third group of women who received the imlunestrant in combination with abemaciclib. And in that group of women, the amount of time the cancer was controlled was even longer than with either of the single agent drugs. That use has not been fully reviewed and approved by the FDA yet, but it's something that might have potential in the future. And as I mentioned, this drug was just approved by the FDA towards the end of September, so it's just kind of coming. It's just becoming widely available. In addition to those oral SERDs, there are some other types of medications, some medications with alternative mechanisms of action for women with ESR1 mutation. One example of that is a medication called vepdegestrant. It is a pill with a slightly different sort of mechanism for destroying or degrading the estrogen receptor. It also increases time of control of the cancer in women with ESR1 mutations. This has been studied, and these results have been shared with the scientific community, but it hasn't been approved by the FDA yet. It's under review, so potentially sometime in the next year it'll become available as well. So moving on from ESR1, what about some of the other mutations that we look for? There are a group of mutations that are part of what we call the AKT pathway. The AKT pathway is an alternative pathway that leads to resistance sometimes to standard anti-estrogen therapies. And there are a number of genes that are involved in the pathway, but 3 in particular that can be targeted are the PIK3CA mutation or gene, the AKT1 gene, and the PTEN gene. So when mutations in those genes are seen, a medication that can be useful in combination with fulvestrant is called capivasertib, or TrueCap is the brand name there. It is targeting a similar part of the of cell communication as this older medication called Piqray that many of you may have heard of. Piqray is an older oral drug that has a lot of side effects and was difficult to use, I think, for many women because of the degree of side effects that came along with it. Capivasertib is approved for all 3 of these mutations, or for use in women whose cancer has all 3 of these mutations, or any of them. They don't have to have all 3 at once, just any one of them. And it seems to be useful in women who have spent even less than 12 months on their first-line endocrine therapy. It can cause some side effects, some GI side effects, and some rash. It doesn't cause as much high blood sugar as the Piqray, but it does still require blood sugar monitoring. And Sometimes, I mean, really not, it's not rare that a woman, when she progresses on first-line therapy, might not have any targeted mutations. And so in that case, we ask questions like, should we keep going with our CDK4/6 inhibitor when we change the underlying anti-estrogen medication? There have been a couple of different trials, or more than two, but I'll talk about two, that look at this question. The first of those was called the PACE trial. The PACE trial looked at, or had two groups of women in it, women who had progressed on their first-line treatment with their CDK4/6 inhibitor, and they received either fulvestrant, the standard approach by itself, or fulvestrant with palbociclib. Now, most of the women in that trial had gotten palbociclib as their first CDK4/6 inhibitor also, so this was really a continuation of the same drug for these women, generally speaking. And when using this approach, unfortunately, there wasn't really any sort of improvement in how well fulvestrant performed. The cancer progressed at the same kind of pace in both groups of women. But what if we switch? What if we change the CDK4/6 inhibitor to one of the other two? So the MAINTAIN trial gave us some information about that approach. It compared in second-line therapy in women who had gotten a CDK4/6 inhibitor, it compared new endocrine therapy alone or new anti-estrogen therapy plus ribociclib. And for about 88% of patients in that study, that ribociclib was a change. It was a different CDK4/6 inhibitor than what they previously received. In that case, the fulvestrant with the ribociclib did improve time on therapy. So this doesn't, kind of tell us about every situation with switching CDK4/6 inhibitors, but it does give us some reason to believe that that they might be useful if there are no targetable mutations present. For the sake of time and for the sake of allowing questions, I'm gonna not really talk specifically about medication, non-anti-estrogen medications for hormone receptor positive breast cancer, but I will say also just a little bit about trial options that are available at the Yale Cancer Center. The trials that we have tend to turn over time, so specific trials, kind of come and go, and we open new ones and we close. But to think about some of the common questions or the themes in the questions that are really at top of mind right now. So one, kind of common theme of the questions being asked by trials for hormone receptor positive breast cancer is, with all of these new drugs, are there ways that we can combine them into larger combinations and get better results for cancer patients? So for instance, we have a trial right now that combines capivasertib, that AKT pathway inhibitor, the TrueCap medication, with a CDK4/6 inhibitor and with fulvestrant. And this is a trial that's looking at women who have the targeted mutations and women who might not have the targeted mutations. Another type of question we're asking is, are there novel ways that we can administer these medications that reduces side effects, reduces toxicity? So for instance, we have a trial for older women over the age of 65, looking at whether or not we can give the CDK4/6 inhibitors in the first-line setting, starting at a low dose and going up, rather than starting at the highest dose that we offer and going down if the dose is too high for them. And then, of course, there's always new drugs. And so we have novel drug trials too. An example is this drug, which doesn't even have a kind of scientific name yet, but still sort of an industry shorthand, Relay 2608, which is a selective PI3 kinase inhibitor. And that selective adjective sort of refers to its potential to maybe have fewer off-target effects, and those off-target effects are what cause toxicity. So potentially fewer or less toxicity than some of the existing drugs in this class. So I think I'll stop there, and we could open it up for questions. And maybe I'll stop sharing too. So you don't have to look at a black screen.
Yeah, Dan, the question that on HER2-low disease, and kind of you can see it in the Q&A. It may come up as answered, but I think it's the question that is a wonderful one in terms of what to do in the setting of HER2-low, hormone receptor positive breast cancer, and how you're envisioning kind of the sequencing of HER2 ADCs in this setting, kind of earlier versus later. So if you could share your thoughts on that.
Yeah, yeah, absolutely. This is a question that actually applies to both the types of breast cancer that Dr. Schellhorn and I spoke about. So HER2 low is sort of a newer idea in the breast cancer space, or almost like a new classification for breast cancers. That three buckets that we've been talking about is sort of how we classically thought about breast cancer subtypes. But I think in Dr. Schellhorn's slide describing what HER2 is, you could see on that normal cell that there was still HER2 protein. Like it's when we talk about HER2 negative cancers, that doesn't mean there's no HER2 protein. So HER2 low breast cancers refer to HER2 or breast cancers that have some HER2 protein, but not necessarily this overexpressed amount, this like extra HER2 protein that has typically made those cancers more sensitive to the anti-HER2 drugs. Why that's an important distinction to make now, why it's important to identify cancers that have some but not too much HER2 protein, is because one drug in particular so far, and surely more in the future, one particular drug, the trastuzumab deruxtecan, the Enhertu drug that Dr. Schellhorn talked about, is actually effective not only in classically HER2 positive breast cancer, but is also effective in HER2 low breast cancer. So if you're hormone receptor positive, HER2 negative, but HER2 low, then Enhertu can be very effective. If you're triple negative but HER2 low, that Enhertu can be very effective. And so we've been using that drug for several years now for those types of breast cancers as well. In terms of sequencing, the standard, I would say, is still for hormone receptor positive breast cancer is to really make the most of the anti-estrogen therapies. Those cancers are still most sensitive to anti-estrogen approaches, like the anti-estrogen medicines work best and longest for hormone receptor positive breast cancers early on. They tend to have fewer side effects. Experiences can be mixed, actually. I don't want to say that Enhertu has a lot of side effects for everyone, or that the anti-estrogen medications don't have side effects that can be significant. But oftentimes they have fewer side effects than the Enhertu medication. So we still try to use as many anti-estrogen medications as possible before changing to infusional chemotherapy-based medications. And then there is some recent conversation about whether Enhertu should be the very first drug that we use after anti-estrogen medication, or if chemotherapies can still, if a chemotherapy before moving to Enhertu is appropriate. And that conversation is really based on balancing length of response versus side effects, and whether or not a drug that might control the cancer longer but have more side effects, whether or not you could kind of get the same effect by turning to that drug a little bit later. It's an exciting space. I mean, and it's a space where I think there will be a lot of new medications over the coming years.
And I think for the listeners, this is your opportunity when these junctures are occurring in your care to be asking your oncologist, what are my options? What are my alternatives? And I think what we all aim for is to summarize currently, as my colleague just mentioned, there are so many options for each line of therapy in breast cancer. So a lot will come down to patients actively deciding with their oncologist based on preferences of schedule, side effects, and so many other considerations. So don't be afraid to be bringing up these questions. We would love to have these conversations. There was a question in the chat that's also an excellent one in terms of when we test for these different targetable pathways. So Dr. Schellhorn will answer that live.
Yeah, no, it's a great question. And Dr. O'Neill talked a lot about targetable mutations. It's applicable for any type of breast cancer, at least to some degree. It's particularly relevant for cancers that are driven by hormones, so the hormone receptor positive breast cancers. Dr. O'Neill mentioned specifically ESR1, looking at anything in the AKT pathway, so AKT, PTEN, PI3 kinase, PIK3CA. as well as a few other mutations that are considered druggable, meaning we have drugs that focus on those molecular and genomic abnormalities and help kind of turn off the switches that might be driving the cancer. And so there's no right answer or wrong answer to how often to be testing. And I think kind of a corollary to this is how to test, because there are a couple of ways that you can test for genomic abnormalities. You can test the cancer itself on a biopsy specimen. So if you have a cancer that's got a deposit in the liver, for example, you could get a liver biopsy to take a sample of that particular tissue and then send it to the lab to look at under the microscope, where we would test for estrogen receptor, progesterone receptor, HER2, and we could also then send it for all of these molecular tests to look for any sort of genomic abnormality. But you can also do what we call a liquid biopsy, which is a blood test looking at DNA from the cancer that might be circulating in the blood and getting that same information in a much less invasive way. So it doesn't require a biopsy or a needle, it just requires a blood draw. And so with the advent of these liquid biopsies, the opportunity is much less risky and much easier to do at any point where it could theoretically change management. And so I think most of us are testing pretty early on, maybe not immediately after a diagnosis of metastatic breast cancer, but again, it might depend on what a patient's story is, what their history is, had they gotten prior treatment, and if so, how long ago, and what medicines were they on. So you might test as early as right then and there at the first sign of metastatic disease. But I think for certain, after progression on first-line therapy for hormone receptor positive breast cancer, because that's when these molecular targets really become relevant after progression on the first line, usually an aromatase inhibitor and a CDK4/6 inhibitor, as Dr. O'Neill described. But then things can change over time and things can develop. So for example, that ESR1 mutation isn't usually very common right at the time of a metastatic diagnosis, unless someone had been on previous therapies. But it can develop in even up to 40–50% of patients who have been on aromatase inhibitors over time. So we would check periodically at the time that there's a sense of the cancer starting to progress, check for circulating tumor DNA, check for mutations, with the idea that if something targetable were found, we could then target it. And the other time to consider molecular testing is when considering clinical trials, because there are new drugs becoming available for particular mutations, certain earlier phase clinical trials that are applicable to patients with certain FDA approved targetable druggable targets at this point. So lots of opportunities, and it's getting easier and easier to do. Kim, I hope that answers your question.
Yes, and there was also an additional question about, is ESR1 testing ever done in early stage breast cancer? And I would say 2 points there. These are acquired alterations that occur under selective pressure of more longer exposure to anti-estrogen therapy. So you're going to have a low chance of finding it early on in early stage breast cancer. However, there are studies investigating adjuvant SERDs in high risk early stage breast cancer. So as often happens, if something is approved and shown to be effective in metastatic breast cancer, we do start testing it in early stage breast cancer. There are a couple of questions in the chat that are complex, so we might need to kind of tag team it. So let's take the question from Dr. Ward. Dr. Ward is one of our amazing breast surgeons within Yale Network. So in the setting of oligometastatic disease and a primary breast tumor, who wants to tackle this? What is the current thinking on breast surgery?
Dr. Ward wants to be a little provocative at our Shares session. So the question is specifically asking if somebody has a primary breast cancer that's in the breast and they're diagnosed with that breast cancer, but they are found to have one or just a few spots on a staging scan. So on a CAT scan or a PET scan, they're found to have another spot somewhere else in their body. Is there a role for doing surgery to the breast? Because at that point, kind of the traditional way that we think about this is that once the cancer has spread outside of the breast, it's no longer considered curable. And so curative approaches, including breast surgery, are generally not considered. I'd say this is an area of a lot of research, especially in HER2 positive breast cancer and in triple negative breast cancer, because sometimes those types of cancers are very, very responsive to chemotherapy. The data that we have to date does not show a benefit to primary breast surgery in the setting of metastatic disease. But these studies aren't perfect, and so there are some ongoing studies being done to look at particular subsets of patients to see if there are benefits. And I will say that for all of the medical oncologists in our practice, we all have patients who they may have had metastatic disease, and they may have had surgery, and they may have had radiation, very strong radiation, with the goal of trying to sterilize metastatic deposits, and they do really, really well for a really long time and don't have evidence of further cancer. I know that there's at least one of them on this call right now who's listening in. So we can't fully explain why that happens, but what our goal in terms of the research going forward is to figure out who are those patients that can benefit from a more aggressive approach and continue to do well in the long run, rather than go through very big surgeries, very aggressive treatments, and not benefit in the long run.
Yeah, I think comes back to shared decision making and really looking at each individual patient, bringing it back to tumor board, which is one of the questions that is densely packed in one of our chat questions, which is, does a single oncologist determine the treatment plan, or is it a collective decision? I can say that if something is very straightforward, the decision is made between the oncologist and the patient in the room right then and then. But any nuances, any complexities, I do want to assure all of you that we're talking all among each other. We're bringing it back to tumor board, and also just encouraging you that if you're unsure or want additional opinions, it's never wrong to explore second opinions. It's actually your right as a patient. Additional questions about just, we kind of answered the question if it's a new cancer, are all markers tested again? And yes, we definitely want to understand the biology of a new recurrence. And I think maybe Dan, take that first part of the question about late recurrences and hormone receptor positive breast cancer and how it can be different with different subtypes of cancer.
Yeah, that's a great question. So just like there are different subtypes of breast cancer, the behavior of different cancers in terms of likelihood of recurrence can be quite different, and the timing can be different. The kind of rule of thumb is that the more aggressive, more faster growing cancers, if they're going to recur, they're more likely to recur in a shorter time frame, or at very least the highest risk periods for recurrence are earlier on. So for HER2 positive breast cancer, triple negative breast cancer, you sort of have the highest risk of recurrence over the first 3 and then over the first 5 years. And as you get further from that period of time, the likelihood of recurrence gets lower and lower. HER2 positive breast cancer has a lower, or hormone receptor positive breast cancer has a lower likelihood of coming back, period, in most cases when sort of size and other things are all considered. So you're for early stage breast cancer, hormone receptor positive breast cancers are less aggressive, less likely to come back, generally speaking. But that because they're slower growing, sometimes the risk of recurrence over time doesn't always drop off to 0. You can have a low risk of recurrence that can continue out for years sometimes. I think at 20 plus years, the likelihood of the cancer coming back is probably quite low. Just the proof is in the pudding over time that it hasn't recurred. But there are situations, I think, that we've all seen where sometimes there can be late recurrence, and it's important, I think, for women to just be mindful of their bodies and what's going on with their bodies, and not be shy about letting their doctors, be it an oncologist still or a primary care doctor, whomever they're getting their care from, know if something feels unusual. If that cancer comes back, is it always metastatic? Not necessarily. There are 2 types of recurrence. There's local recurrence and distant recurrence. And distant recurrence sort of refers to that metastatic disease, the disease that's in organs outside of the breast or outside of the nearby lymph nodes. Local recurrence can be the cancer coming back right in the breast, either usually in the vicinity of where it was originally, or sometimes in the lymph nodes that are surrounding the breast. That is often the first kind of place cancer begins to travel to. So either of those situations are possible. I mean, that's also the reason why it's important to keep getting mammograms. The other reason why it's important to keep getting mammograms is because as long as you're a woman alive with breast tissue, there is some risk of developing a new breast cancer. And just because you've had a breast cancer in the past doesn't mean that you can never have a breast cancer again. So continuing to get mammograms so that you pick up on any new breast cancers when they're still early is important. New breast cancers can certainly show up. I could talk a little bit about, I think we have a couple of minutes.
Yeah, and just to clarify for the audience that, but in the setting of active metastatic disease, you're getting thorough scans frequently. So in that setting, when we do not recommend additional routine mammography, that has not been shown to be helpful.
Yeah,
We're almost at time. Just one remaining thing is that in metastatic disease, unlike early stage breast cancer, the treatments continue as long as they're helping you and as long as they're controlling the disease process. But there are situations where there may be, we've had times where disease has been completely stable for some time. So again, comes back to shared decision making about whether a certain type of de-escalation or therapy break can be considered. But generally, things are left open-ended as long as they're helping you and keeping the disease at bay. Lots of different chemo cycles and targeted schedules, so we won't get into that. Definitely ask your oncology team about that. But you've all been such an amazing audience with really great questions, and I want to thank again our speakers today, Drs. Schellhorn and Drs. O'Neill, and thank you so much for joining us. Thank you, Mary Ellen, for joining. Thank you. Bye-bye. Bye-bye.
Have a good night.